o'clock, so let's get started. What's left for us to discuss on breast cancer, as I mentioned at the end of Monday's lecture, was that we were going to go over two drugs. They're both anti-metabolites, and they are very commonly used in breast cancer and in other types of cancer. Capecitabine, when it's given, it is converted by carboxyesterases to 5'-deoxy 5-fluorocytidine. 5'-deoxy 5-fluorocytidine. And then that FRC, or DFRC as we call it, will get converted by cytosine deaminase to 5'-deoxy 5-fluorouridine. 5'-deoxy 5-fluorouridine. And that 5'-deoxy 5-fluorouridine can be converted to 5-FU, 5-fluorouracil, okay, by that deoxythymidine phosphorylase. Deoxythymidine phosphorylase. Okay, and once 5-FU is produced, it can then be metabolized to FDUMP, 5-fluorodeoxyuridine monophosphate, and the FDUMP is what would inhibit DNA synthesis. But 5-FU can also go to 5-fluorouracil triphosphate. 5-fluorouridine triphosphate. And the FUTP is the one that would inhibit RNA. So FDUMP would go to the inhibition of DNA, and FUTP would go to the inhibition of RNA. So that's how capecitabine works. Two things that are important along that pathway: that cytosine deaminase can actually be inhibited by a drug that we said you could use for the treatment of MDS, because the last time that we met, we discussed the MDS, and online on Monday, we listed some drugs that you can use to manage MDS. So that's one of the drugs that we mentioned. Okay. Now, quickly, just some major adverse effects of capecitabine. It causes what is known as palmar-plantar erythrodysesthesia. Palmar referring to hand, the palm, plantar referring to foot or leg, and so it's called the hand and foot erythrodysesthesia. So they just say hand and foot syndrome. That's how they refer to it sometimes. Okay, so that is a distinguishing adverse effect of that drug. Gill's is referring to GI, that is GI symptoms, nausea, vomiting, diarrhea, anorexia, dyspepsia, all of those it can cause. And then L is referring to liver, so increase in ASP, AST, and all those. So liver damage. And then the skin, it can cause what is called desquamation. So you can just see the skin will just be peeling off. It will be scaly, and of course that's very unpleasant. And then what stands out again will be the labs. So we're talking about lethargy, and the A there is asthenia. And that is a very unusual weakness. It's a generalized severe weakness. It's not just regular weakness that one can feel. So asthenia, and then you can talk about fever and fatigue. Fever and fatigue. So those are the adverse effects that stand out about capecitabine. Gemcitabine is also an anti-metabolite, and like all these anti-metabolites that are used in cancer, it will get converted to its diphosphate form. Okay. When it gets converted to its diphosphate form, that can inhibit ribonucleotide. Well, before it gets to the ribonucleotide, it will get to the side, nucleoside. And then it gets to the nucleotide. So ribonucleotide diphosphate reductase, RDR, ribonucleotide diphosphate reductase. So that's how it will work. If you inhibit that enzyme, you will not be converting a ribose sugar to a deoxyribose sugar. Okay. So you will not basically be forming a part that will go into DNA. But as its triphosphate form, it can directly inhibit DNA synthesis. So there are some other popular drugs that work through the RDR inhibition. It's a drug that is called pentosacin. Well, it's it is sometimes called 2'-deoxychlorphomycin. Deoxychlorphomycin. That agent can also inhibit RDR, but it is used for what is called oat cell. oat cell leukemia. And that is perhaps the most deadly form of SCLC, small cell lung cancer. So, an inhibitor of RDR is that agent. And some of the common side effects or adverse effects of gemcitabine, you see a drop in all these electrolytes. Blood pressure can come down, sometimes it can go up. So you can have both under gemcitabine. And then capillary leak syndrome, you heard a lot about that when the viral infection that took the nation by storm just came out. So the only management you have for it is just supportive management. You know, you just have to take care of the blood pressure, take care of all the fluid accumulation and stuff like that. But that can be produced by gemcitabine. HOS, we mentioned that under 5FU last semester, you know, so acute respiratory distress syndrome, or ARDS, is another prominent adverse effect of gemcitabine, and the cardiotoxicity can be of different forms. You can have angina, you can have MI, all of those can be present with that cardiotoxicity. Different forms of arrhythmias can also be present. You can also have what is just called cardiogenic. Cardiogenic manifestation of the cardiotoxicity of that gemcitabine. So all of those can be seen with those two drugs. We have the hemolytic uremic syndrome that we talked about under 5FU. So those are the things we want to quickly go over to finish up the breast cancer.
Dr. Mo.
Yeah.
ARDS is acute respiratory distress.
Distress syndrome.
Okay, thank you.
So now we can start prostate. Okay. So we look at some anatomy of the prostate. We know that it is relatively small in size. It's about the size of a walnut. Very small. And we know that it covers about the first 1.5 inches of the urethra. So terms of location, it is around the, well, let's say it is just above the rectum. That's why you can do that rectal examination when they're trying to diagnose prostate cancer. And it's just below basically the bladder. So it surrounds the first 1.5 inches of your urethra. Okay, so that's what it looks like and where we can find it. Now, it has 2 lobes. And we say it has 2 lobes only if you're talking about functionally. See, anatomically, it actually has 5 lobes. And you say it has 2 lobes, mainly because those 5 lobes, you have 2 lateral lobes. You have one anterior and one posterior. And then you have one that is like central or median. That's so that's how you got 5. But these 2 lateral lobes are the largest. They're, so much larger than these other 3. And that's why we just usually say the prostate gland has 2 lobes. And those 2 lobes are classified or categorized as right and left lobes. Now, during the diagnosis of, say, prostate cancer, that's where this comes or becomes important. Because there is something called Gleason score. And to arrive at that Gleason score, you basically look at these 2 lobes, if you do it this way, 2 lobes, and you assign whatever number you got from looking at the activities that are going on in those lobes. In other words, you look at the degree of differentiation that is going on in those 2 lobes. And you assign a number based on how active those tissues are. And you assign a number, and then you say whatever number you got, you multiply it by 2 to cover this so-called 2 lobes. If you came up with a number that is around 2 or 4, that is low. So that means there isn't too much activity going on in those lobes. Okay. But if you came up with an 8 or 10, that means the tumor is excessively working, or is too active that means that it is a serious or at a very serious level. So the Gleason number, we want it to be as low as possible, but it's actually referring to the activities that are going on in these right and left lobes. But anatomically, it actually has five lobes. Now, the prostate also has zones, and there are three zones. Three zones. Okay. One is the peripheral zone, okay. And then one is the central zone. And then the third one is the transitional zone. The transitional zone is the zone that is the closest to the bladder. So if you're going from outside to inside, it will be peripheral, that will be the outermost. And then the transitional will be the innermost, part of that prostate. So those are the three zones, and most of your breast cancer cells or tissues come from here, the peripheral.
I'm sorry, can you repeat that?
Most of the prostate cancer cells will start right at the peripheral zone, that is on the outermost. Okay. All right. So if we look at the function, if you will, of the prostate, its main function is actually to produce that antigen, prostate-specific antigen. It can also contribute to the ejaculation volume. It secretes a fluid that is basic in nature, that is in terms of pH, and that is kind of milky, and it adds volume to the ejaculate that comes out.
What is PSA?
This prostate specific antigen is basically a glycoprotein. It's a glycoprotein that is produced by the prostate only, and that can be used to mark the activity of that prostate gland. So that would be it in terms of function. Let me just jump ahead and state that the PSA is not definite. It's not used as a definite diagnosis for prostate cancer, because PSA can go up if you have an inflammation, just an inflammation of the prostate. Your PSA will go up. If you have prostate cancer, of course, your PSA will go up. If you have BPH, your PSA will go up. Okay. So it's not a definitive factor.
Stevenson? But we can use that for BPH, right? It's much more specific for BPH.
Yeah, but
We're not going there, right?
It could mean any one of those.
I'm just trying to tell you that for prostate cancer, it is not specific. I mean, it is not definitive, because PSA can go up in different conditions. Okay. But it can help if you just want to do some zoning or what have you. But it's not something that we just depend on excessively.
How about the volume? Is the marker?
It's a marker, yeah.
Volume is a marker?
Yeah, the volume that is produced by that prostate gland, okay, how much of PSA is in there can be a marker. Okay. But the volume can also, or the production of PSA can also be used as a determinant of whether you want to start a therapy or how effective that therapy is going, or if you should stop therapy, duration of therapy. So it can be helpful in that situation. So whether you want to initiate therapy, continue therapy, or stop therapy, you can use PSA volume or production for determining those. Okay, so and say in the past we used to say that 0.4 nanograms per mil of your PSA is normal. And when you get up to 4, you could be having BPH. And when you get up to 10 nanograms per mil, you'll be looking at severe BPH or prostate cancer. Okay. But there is a change in that now, because you're using gradations based on age. If we go from 40 to 50, 50 to 60, that is years of age, 60 to 70, 70 to 80, you don't want to care about after 80. Okay. 40 to 50, the normal now is taken to be like 2.5 nanograms per mil. If you're looking at the PSA. The patient who is aged between 50 and 60, the normal for that person is like 3.5. And so you just add 1 to it up until you get to 80. So for a 40 to 50-year-old, 2.5 to 3.5 nanograms would be fine. 50 to 60, 3.5 to 4.5, if you want to use that range. And then 60 to 70, within that range. 70 to 80, 6.5 is still normal for that patient. So it doesn't have to be the old 0.4 or that universal number. So they go by age now.
And again, those are normal values. They're just coming out.
Huh?
Those are normal values.
Those are normal values, yes. So it's not one universal number anymore, like 0.44 and 10. So that's not used anymore. Okay, so that's in terms of the function. There is some suggestion that it probably has some antibacterial or antibacterial function. You know, that is still questionable. You know, whether it's strong enough to be considered a real function, but that it has some antibacterial effect. All right, and now we can go ahead and look at pathology. So now we are considering prostate cancer. So if we look at just distribution worldwide, you'd say prostate cancer would exist in, 1 in 6 males. That's the occurrence, 1 in 6 males. It is greater in shall we say African Americans or just blacks in general. It occurs more frequently in African Americans than non-African Americans or non-blacks. And it seems to be related to the level or concentration of testosterone. The more concentrated or the higher the volume of testosterone, the greater the chance or likelihood of getting prostate cancer. And if we look at the etiology, unknown, just like for every other cancer, the actual etiology is not known. And so we can talk about the risk factors. For the risk factors. 1, family member. If a family member, and if it's the first string, a dad, what have you, ever had prostate cancer, chances are you can get prostate cancer. So the first circle of family, okay, if they ever had that cancer, your chances are high of getting it. And the age at which that family member got it also matters. The earlier, the worse. In other words, if that first member of the family that had prostate cancer got it at say 45, 50, your chances of getting it are increased. as opposed to if the first member got it at 70. Okay. So that's one. Two would be what we would call familial, that is in terms of hereditary. If a member of the family had, say, mutated P53, the same P53 gene that we referred to under breast cancer, you know, and chances are, or the risk of getting prostate cancer will go up. And the same goes for BRCA, you know, BRCA1 and BRCA2. Chances will go up, so increased risk. There is something that is called, you know, prostate cancer, just like BRCA. You know, prostate cancer gene, it is a tumor suppressing gene, and so if its elaboration or if its production is inhibited or is downgraded, then of course one would have an increased chance of getting prostate cancer, because BRCA1 is a suppressor gene. If you inhibit the suppressor, then it's like basically activating. There's also one that is referred to as human prostate antigen, HPA. So HPA is also a suppressor gene, and that can also elevate one's chances of getting prostate cancer. There's one called Chi1. Chi1 Kenge, that's the full name, is also a suppressor gene. So if you decrease its production, then you can increase the chances of getting prostate cancer. Cadherin. That can also lead to an increase in prostate cancer development. That is, it's a glycoprotein that is responsible for adhesiveness of cells. So if you lose that adhesion, then of course you will be more likely to get, more movement in your cancer tissue or cancer cells. So all of those would elevate the chances of getting. And three, there are some other factors like, say, insulin-like. Your insulin-like growth factor tends to increase the growth rate of prostate cancer. So insulin-like growth factor, that's one. And if you have had vasectomy, that would also increase the chances of getting prostate cancer. Now, if you had orchiectomy, that reduces the chances. You know, if you remove the testis. So, where's that? Orchiectomy. Ectomy means removal. So if you remove the testis, you decrease the chances of getting prostate cancer. But if you remove the vas deferens, because that's what you're doing with vasectomy, vas deferens, you're removing the vas deferens, your chances of getting prostate cancer would go up. And if you indulge in fatty food, okay, fatty food also increases the risk of getting prostate cancer. Now, there are some things that will reduce the risk, and those factors that we will mention now, they are sometimes used in the non-drug treatment of prostate cancer. You know, so in other words, you can use diet as a non-drug treatment of prostate cancer. Some things like your garlic is all right. Tomato, that is because tomato has lycopene. Has lycopene in it that is going to reduce the chances of one getting prostate cancer. Things like pomegranate can also help to reduce the chances of breast cancer. Some kinds of fish, you know, trout will decrease the chances of getting prostate cancer. Sardines would also decrease the chances of getting breast cancer. Certain nuts, peanuts would help. Cashew nuts would also help because cashew nuts and peanuts have a high concentration of zinc, and zinc would tend to decrease the proliferation of your cancer cells.
What about walnuts?
You know, huh?
Walnuts.
No, walnut doesn't.
In the walnuts.
We're not saying that walnut is bad, we're just saying that it's not one of those, you know. So those can help. We'll mention some more later on. That's the issue about the risk. Now, we can quickly look at the staging. So for staging, you will use the same system that we use in breast cancer. So it will just be the TNM, you know, in situ tumor, then the nodes, and of course metastasis. So that's where the staging will be done. When we talked about when we say metastasis for prostate, it can spread just locally. So local spreading, that would be contiguous spreading, where it just spreads from the prostate to like the bladder, for instance. Then it can spread, of course, lymphatically through the lymph. Can travel by the lymph. But the most important means of spreading is through the bloodstream. When it spreads through the bloodstream, the first place or the most common place that it goes to is the bones. That's why you can do an ultrasound of the bones to see whether it has come over there. And then it can spread to the liver and then to the lungs. So that's how it metastasizes or it spreads. Okay. So if we look at the types that you can get, types of prostate cancer, those are the ones I've written up there. The most common type, of course, is the adenocarcinoma. That is because the prostate gland mainly contains glandular tissue. Okay. It's about 98% glands, so it's mainly glandular, and you know by definition that we did the first time, adeno, that would be glandular, you know. So most of your prostate cancer will be a type of adenocarcinoma. But there are some other tissues that are referred to as carcinoma. Okay. So, for instance, you have connective tissues in the prostate. So if it occurs there, it will be a sarcoma. It will not be an adenoma or carcinoma. So you can have a sarcoma of the prostate gland. That is usually seen in very, very young patients. So if prostate cancer exists in a very young person, under 40 years of age, okay, it will be a sarcoma of the prostate gland. It will not be a carcinoma. And squamous cells can also become cancerous, so the tissue or the cancer or tumor can arise from squamous cells. And then in the duct, the ductal transitional carcinoma, because that will still be within the prostate. If the prostate cancer is undifferentiated, if you say it's undifferentiated, then it means that it is, irregular kind of. Okay? So that means that it will be very aggressive. So it will be aggressive if it's undifferentiated.
Could you please repeat the word is undifferentiated?
Undifferentiated means that.
No, which one is undifferentiated, you said?
No, I'm just saying that you can classify prostate cancer in terms of their aggressiveness, If it's undifferentiated, it will mean that it will be very aggressive because it doesn't care about function. Okay, if it's differentiated, it means it cares about function. That would be less aggressive. Okay, that's so. Any of these four right here can be differentiated or undifferentiated. Okay. It's just to classify the aggressiveness of it. You can also see this term used, diploid, you know. So that would mean that the cancer still has your usual number of chromosomes. Okay. That is, it would exhibit, the usual number, that is the normal number. So if it's diploid, it will not be aggressive. If it's aneuploid, then aneuploid. Then it would be, I think that's E there. Then it would be very aggressive. See, that would mean that the number of chromosomes in it will be varied. It can fluctuate any which way. So this aneuploid will be very aggressive form of prostate cancer. So those are the different types. We'll pick up on the signs and symptoms and finish it up.